us call upon Dr. Mohit Gupta, who is a lucid elaborator on any subject, especially other than even the medical science. So, Dr. Mohit Gupta, please, on stage B, heart failure. So much.
Very good afternoon, Chair and my dear friends. I'm going to unravel the science. It's always a privilege to have my dad sitting along with me. Thank you so much for this privilege. Thank you.
So why did you stop at only one Mohit Gupta? You should have produced more.
So I'm going to take you to the science of stage B heart failure. Let me tell you, I'm going to give you only 8 messages, and that is going to give you an idea about what we are missing today in our life. This is what is happening. Can I have which is moving? Slides, please? Excuse me? Yeah. This is what is happening. We are all focusing on stage C and D heart failure, which is reduced ejection fraction or a preserved ejection fraction. But 60% of the giant that we are facing today is actually the stage B heart failure, which all of us are commonly saying. Why this is concerning? Because heart failure in India, we have little education. In fact, most of the doctors and physicians are also not aware of the stage B heart failure, presenting at a much younger age, and most of them are often asymptomatic. So my first message to you is, what is stage B heart failure? It includes patients of structural heart disease with no current or prior heart failure symptoms. That's the crux. So you have a heart failure patient which has an asymptomatic LV dysfunction, and you are borderline treating this patient with some medicines. Probably patient is asymptomatic, koi problem nahi hai. Let us go ahead with this. Why and what is the prevalence of stage B heart failure? Almost 50 to 60% of the Western data and Indian data. Dr. Rakesh Gupta has himself published the data in Indian Heart Journal, which shows 52% of the patients of heart failure that we are seeing are in stage B heart failure. Koi baat nahi. Even if we are seeing stage B heart failure, why is it concerning? This is concerning because stage B heart failure is what is going to progress to stage C and D heart failure. And the studies, couple of studies that I'm going to show. The first one by Gori et al. It has shown that those patients, look at this, those patients who had normal LV ejection fraction, those who have only mild systolic dysfunction and no diastolic dysfunction, those patients who have mild systolic and diastolic dysfunction but all are asymptomatic, over the years they progress into symptomatic heart failure significantly. That's a major concern. To complement this, look at the Framingham Heart Study. In the Framingham Heart Study, what we saw was those patients who had mild asymptomatic LV dysfunction, who had asymptomatic LV dysfunction but no symptoms, and who had moderate asymptomatic LV dysfunction, almost all of them had deterioration which was very, very significant. And that is what is concerning about stage B heart failure that we need to be aware of. Why should we be concerned? The reason is because there is high risk of progression to symptomatic heart failure. Prevention is better than cure. So we should strike these guys right at the beginning. Second, it is often undiagnosed and unmonitored. Most of us would not be concerned. We are more focusing on what we are saying, a heart failure, reduced ejection fraction. Now those guys, no. This is where it is undiagnosed and unmonitored. We have to take care, and an early treatment will give you great outcomes. You are going to save this guy from going into a stage C heart failure if you treat them right on the point. So what are the common etiologies? भाई क्या क्या हम लोग देखते हैं? A case of a coronary artery disease, simple. A case of a hypertension, a case of a valvular heart disease, and a case of a cardiomyopathy with LV dysfunction who's asymptomatic. These are the substrates who are going to develop, and even diabetes, who are going to develop stage B heart failure. This is the pathophysiology, not going on into the details given the time, but it's about the ventricle remodeling that is taking place, and what happens when this ventricle remodeling is unable to take care and compensate for what is happening inside. The ventricle dilates and it leads to the development of stage C heart failure. This is how the whole system is functioning. How do you diagnose? Now this algorithm looks really messy, and you obviously are not going to remember this. I'm going to give you a clinical mantra that was published only 2024, and that is called the BEEF score. Look at this. If you have a patient whom you are suspecting to be in stage B heart failure, just measure these 5 points and you are going to diagnose and pick up stage B heart failure significantly. If you have a BNP of a patient more than 150, you get a 1 point. If you have a eGPR very easily calculable less than 45, you are going to get 1 point. If E by E prime is more than 14, typically it has been more than 15, again 1 point. Anemia in any patient less than 13 and less than 12 in males and females respectively, 1 point. And then you have a frailty, 2 points. High risk is 4 to 6, moderate is 2 to 3, and low risk is 0 to 1. Reasonably validated score. Coming on to the management, what are the challenges? Patient will say, मुझे symptom तो है नहीं जी, आप दवाइयां किस बात की दे रहे हैं? That's the problem. That's the problem with the mindset that most of the patients and often the doctor are having. Because most of the therapies that we have today, like SGLT2, like ACE inhibitors and beta blockers, they are reasonably expensive for the poor patients. So treatment compliance is a major concern, and paucity of evidence-based recommendation. Practically, we have no significant focused trial that are focusing on stage B heart failure. So patient with ALVD, that means asymptomatic LV dysfunction, is feeling good. He is unwilling to take medicines and he says side effect और हो रहे हैं जी मैं क्यों लूं, and more so we have limited data and increased cost is going to burden the patient. But let me show you what data we are having. Look at this. The patients who have in stage B heart failure, you have to give them all the medicines of stage A. That means controlling hypertension, controlling diabetes, giving them optimal lifestyle modification, smoking control. Along with this, there are 4 medicines that you should be using judiciously in these patients. ACE and ARB. ACE inhibitors is what is significantly and very well investigated. Not going into the details and the numbers, 3 trials, SAVE, SOLVE, Prevention and TRACE, old age trials with more than 4,000, 5,000 patients, majorly asymptomatic patients. Look at this. Death due to worsening heart failure is more than 25 to 30% reduced in these patients. So you have a ALVD patient, you put them on reasonable ACE inhibitors, Ramipil or enalapril, you are going to save that patient from developing heart failure. And not only this, the mortality risk reduction is also significant. If the patient is intolerant to ACE, definitely ARBs can be given, but not very well investigated. Not only this, you give a ACE inhibitor, the ECO sub-studies have shown that remodeling of LV is great. LV mass decreases, LV end diastolic volume also decreases, and these patients have a better ejection fraction on long-term follow-up. Look at this beta blockers. The studies again show SOLVE, Prevention, SAVE, Capricorn, all these are showing death due to heart failure is again more than 30% decreased. So in these patients who have an asymptomatic LV dysfunction, stage B heart failure, come on, give them a good beta blocker of your choice, whatever you like. It could be a propranolol, it could be a retinol, it could be even a carvedilol, it could be anything. But put them on a beta blocker, you're going to save his life. And not only this, it is also like ACE inhibitors reversing the LV remodeling as shown by the REVERT trial. Statins in patient of myocardial infarction are obviously great and recommended. And look at the newer evidence of SGLT2 inhibitors. Surprisingly, no trials have specifically investigated stage B, but today the sub-analysis of DAPA-HF, of Emperor reduced, and even the preserved cases, the Emperor preserved and delivered trials, they have shown that there is significant reduction in primary endpoint of worsening heart failure. That means chancing of them developing heart failure and cardiovascular death is much less. Much less. That is why it is important that dapagliflozin or empagliflozin, whatever you want to give, this is going to benefit. And this is what guidelines are showing. They have not specifically recommending, but both stage B and stage 3 heart failure, SGLT2 inhibitors are in. ARNIs, poor evidence. We have practically no evidence of using ARNIs. Now, this is where we have to take care. Somebody is promoting ARNI, we are going to write an ARNI to a patient of LVD, not recommended at all. ARNIs have failed to show benefit in asymptomatic heart failure, whether it was Paradise MI, whether it was other trials, there is no benefit in these. Finrenon is another drug in patients of diabetes and CKD that has shown benefit. And lastly, we have devices. All patients who are less than 30% ejection fraction, who have asymptomatic LV dysfunction, motivate them, promote them to take and go under a ICD implantation, because you are going to decrease the mortality chance by almost 31%. So what I want to tell you is stage B heart failure is a common entity and requires a simple diagnostic score. That is what I gave you message. Its significant proportion are going to worsen, and management strategies have to be individualized. My message has always been and will always be, look beyond the obvious. All modalities should be used wisely with clinical experience. Why? Because a fool with a tool is still a fool, my dear friends. Thank you so much for our
Thank you, Dr. Mohit Gupta. Could you stay back for a few minutes? Very thought-provoking lecture. In fact, I'll invite one or two questions from the panel and one or two questions from the audience.
In diabetic diastolic heart failure with normal epicardial arteries, there is evidence that the microcirculation, coronary flow reserve is reduced. So, is there a case for giving aspirin in such cases?
So currently the guidelines don't recommend it. Aspirin is contributed and given in patients of ALBD and stage B heart failure only with compelling indications, like if the patient has an underlying myocardial infarction, a coronary artery disease, and something like that, then only aspirin is given. But otherwise, as far as my knowledge and research goes, that there is no study that is specifically documented, and even the guidelines don't endorse the routine use of aspirin in patients of ALBD and stage B heart failure.
In diabetics?
I think it's very important, Mohit. I really want to compliment you. And I think you mentioned very, very clearly, hit hard, hit safe, and hit early.
Yes.
That's important message. Second point which you mentioned is on SGL2. I think it's a very beautiful expression on SGL2 because it may cause LA remodeling reversal, LV remodeling reversal, and the vascular remodeling reversal. So that's an achievement. That's a power. It's a beautiful expression. Thank you
so much.
Dr. Mohit, you just slightly touched on phenylalanine regarding the newer indication which is coming. We'll just highlight because it's into the DGCA for recommendation.
So that's one of the in thing and the new molecule. Phenylalanine, we have only one trial, Fine Hearts trial, in which patients who were asymptomatic, who had CKD and diabetes mellitus, as I showed, they are precursors of asymptomatic heart failure. Phenylalanine showed a significant benefit in LV remodeling and also decrease in mortality. So this is one of the molecules that is in, and guidelines are now openly endorsing. The European Heart Guidelines in 2023, they've endorsed the use of phenylalanine, but only in specific indications in patients of CKD and diabetes mellitus, not in routine use in all the cases. So this is because the data is limited only with one trial. So, but it was a randomized and important trial. So they have been endorsed, but not a blanket usage in specific indications if it is due to diabetes and CKD.
What about the future when we have a hypertensive patient who has got urine microalbuminuria? Can we think about using this molecule?
Great idea, but it needs to be validated. It needs to be investigated. We cannot extrapolate a use of an expensive drug which has not been proven in a definitive indication.
Because it initially started with SGLT2.
I think that it is holding a great promise, but there are trials which are underway. Let us have the results out, and probably then we can use it. And this is it. Yeah, please. Sorry? Yes. So diabetic with proteinuria, phenylalanine is kind.
Yeah, that's what I was asking
The
for.
substrate here is patients who are having asymptomatic LV dysfunction and stage B heart failure. You see, I'm not against using in that indication. We are discussing whether these patients who have developed an asymptomatic LV dysfunction, will this drug benefit or not?
I think there's no study to say that it should be used in asymptomatic left ventricular dysfunction.
Thank you.
In the end, I'd like to thank Dr. Rakesh Gupta and congratulate him on his Silver Jubilee celebrations. I remember the day when he was with me in Hindura Hospital and he came to me, sir, I'm going to start the echocardiography. So the day is not very far off, but he's a very bright boy, you must know. And he has worked so hard that he is single man show that he is doing all these things. So I want to congratulate him along with my family and to his family that he prosper much. Thank you very much.
How many minutes we have got?
No further Yeah, the session is going
Okay,
to close.
with a very final note, actually, all the speakers have done excellent job in presenting their ideas and philosophies regarding heart failure management. Let us give a big round of applause to all of them, and we conclude the session here.
Yeah. Thank you so much, all of you. I request all the panelists, the moderator, and the speakers to kindly come on the screen by the side of the stage for the felicitation. Yeah, come in. Come in. And in the meantime, let me take the honor to invite Dr. Rajiv Kumar, who is the Program Officer of State PCP Delhi, NCR. For honoring him, I invite Dr. Rakesh Gupta on the stage, please. A big round of applause for Dr. Rajiv Kumar. Where's the photographer?
He's Dr. Rajiv Kumar. He's a state PCP NDT officer in Delhi NCR, and a very good friend of mine, and he always helps me maintaining the law during my co-training programs. And I want to pay thanks from a core of my heart, left ventricle with both the papillary muscles and cords and tendons, for his presence over here. He is a little bit in a hurry. He wanted to be in an inauguration ceremony, but for some reason he has to rush back to his house. I'll request him to say a few words.
Good morning, everyone. I'm first of all thankful to Dr. Rakesh sir for inviting me for this function. संडे की सुबह सुबह क्लिनिशियंस के साथ मिलने में थोड़ा सा अलग सा मज़ा होता है, क्योंकि हम लोग तो अब क्लिनिशियंस कम रह गए और दूसरे लोग ज़्यादा हो गए तो लगता है क्लिनिशियंस के साथ मिलकर, स्पेशली जब स्पेशल हार्ट कार्डियोलॉजिस्ट के साथ आप डील करते हैं और बैठते हैं तो लगता है कि सब कुछ अच्छा है. बेसिकली आई एम डीलिंग विद द इम्प्लीमेंटेशन ऑफ द PCP-NDT एक्ट इन दिल्ली. And so cardiologists are not much associated with this PCP-NDT Act, but yes, they are in some way associated, because the echocardiography machines that they have been using is to be registered under PCP-NDT Act, and they have to be with the law. So my only message to persons over here who are cardiologists and dealing with the echocardiography, just abide with this PCP-NDT Act, so that there's no legal hassles unnecessary being invited to you people for this regard. I'm once again thankful to Dr. Rakesh and congratulate him for his 25th annual Silver Jubilee for this JROP echocardiography functions. Thank you so much, sir. And I'm sorry to the house as I have to leave earlier, so I have to intervene in between your scheduled program. But thank you so much.
Okay.
Thank you, Dr. Rajiv. Thank you very much.
So moving ahead, we will call upon the stage Dr. Malvika Suchar, Dr. Smita Kudalkar, Dr. Prasanjit Panda, Dr. Tamogna Das, Dr. Manish Bansal, Dr. M.K. Das, and we want to honor all these people for their work on stage B heart failure, published in Indian Heart Journal from JROP Heart Institute. Please be on the stage.
Friends, we are doing a one-year fellowship program under Palur University. That's for last 3 years. Few of my students did their best. She's Malvika Suchak, Dr. Tamogna Das, Dr. Prasanjit Panda, and Smita Kudalkar. They were the 4 people who worked on this particular project of incidence of stage B heart failure, which Dr. Mohit Gupta has just shared with you. And amazingly, and not in a good sense, almost 50% of this population of hypertensive diabetics, they are suffering from stage B heart failure. The people who contributed further to this project was Dr. Manish Bansal, Dr. Samir Srivastav, and Dr. M.K. Das. Dr. M.K. Das is over here. Please come. They helped me out like getting this work organized and getting into for a literature in the sense like everybody goes through it. Look, this is what stage B heart failure is. And that's what Dr. Mohit delivered perfectly today in the morning. Look, we have to look for this prevention. Dr. Das, you're requested on a stage, please. Come over here. Your name is there, although it does not show over here, but your name is there in that paper. So I can have a small plaques. I want to present them on behalf of a JROP for this particular work of stage B heart failure. Thank you. Second is Dr. Malvika Sochak. She is from Thane, Mumbai, doing this work. Dr. Pasajit Panda is an ex-Navy person.
Please give them a big round of applause. It's a good
And their
work.
hard work
Yeah.
is not that like we did it. They did it to come to this level, analyzing more than 660 cases, recording them and analyzing them. And Manish is always helpful whenever we need to have her. So we can have a group photograph together for their hard work. And a message to my other fellows, please fall in line. You're going to be on a stage next year. Thank you very much.